Hello everybody, I'm doing a quick run through on bleeding emergencies of the obstetrical patient. This is for LND, antepartum, ICU, and the ED. So the first couple of slides just talk about cardiovascular blood changes become significant and pronounced beginning as early as the 8th week of pregnancy. The heart rate increases, the cardiac output increases, and even more so as that patient nears term and goes through labor. With a single pregnancy, a mom's blood volume actually increases by 30 to 50%. Blood flow through the uterus is about 500 mils a minute, and they actually have several more liters of blood than they did pre-pregnancy. So with this increased amount of blood and increased circulation, these patients are also at increased risk for bleeding emergencies. These can occur in the antepartum, intrapartum, or postpartum period, or can be a combination of any or all of the above. The three main causes of this being trauma, uterine atony, and abnormal placentation. The trauma, of course, can come from a number of things. There could be an accident, fall, or assault. A lot of times you'll have pregnant women who fall. A lot of pregnant women are also targets of domestic violence due to their pregnancy. Internally, there can be a premature separation of the placenta, which is causes that placenta, that area, to bleed, and it could either bleed externally or it could be bleeding from the inside and be what we call concealed. Or the uterus can actually rupture, being that it's a round ligamented muscle and it's very stretched out, especially later in pregnancy. The uterus can actually open up, leaving the baby free floating in the abdomen, and of course lots of concealed or even external bleeding. Then delivery-related traumas in our vaginal deliveries requiring forceps, lacerations where they tear, or hematomas that result from the highly vasculature areas of the vagina and the trauma that you endure during delivery. So the placenta being abnormal, there's a couple of different things. There's placenta previa. This is something that we worry about whenever our patients come in bleeding heavily before delivery or during labor. There is placenta accreta, increta, and percreta, and not to get too deep into that, it's just that the villi of the placenta actually embed itself into the endometrium, into the uterine lining, and on even into the abdominal cavity, maybe attaching itself to the intestines or the bladder. Vasa previa or filamentous insertion of the cord, and I believe we have pictures of those. This is kind of describing what the accreta, percreta, and increta looks like. Vasa previa is the fetal vessels course through the membranes and present at the internal os of the cervix. Filamentous insertion is when the umbilical vessels are located below the presenting part of the fetus. If this occurs and the membranes break or the mom's water breaks, this can result in massive hemorrhage, both maternal and fetal, and can be deadly to the mom and the fetus. So this is what a vasa previa will look like after delivery, and this is what filamentous insertion of the cord looks like. Both are huge emergencies. Trauma. So excessive bleeding may be a result of trauma to the uterus, cervix, vagina, or perineum. Again, a list of those things that we've already discussed. And to add to that list, surgical issues. So of course, anytime we do an operative delivery by C-section, there is surgical blood loss. Uterine atony. So this is the big one when we think about what is a postpartum hemorrhage. So that's the failure of the uterus to contract following the expulsion of the placenta and contents of pregnancy. And the most common causes is an overdistension of the uterus from retained blood or retained placenta products. Tocolytics, induction or augmentation agents. So those Pitocin receptors of the uterus have been flooded because of augmentation or induction, and now they're not as receptive to the Pitocin afterwards to contract back down. A traumatic birth, whether that be with forceps, whether that be an extremely large baby. Shoulder dystocia, rapid or prolonged labor, general anesthesia because everything else is relaxed, so of course the uterine muscle is also relaxed and doesn't want to contract down. Chorioamnionitis, which is an infection of the amniotic fluid that can occur before and during labor, that can also cause bleeding, as well as multiparity. The more babies that you have, the higher risk you are for hemorrhage. So for the intrapartum patient, whenever this patient comes in, most likely with an abruption, we've had a couple who have come through. A lot of times you're going to have frank vaginal bleeding, and it's going to be a massive amount of bleeding pouring down their legs, pouring in the wheelchair. However, at the same time, you could have an absence of vaginal bleeding, as I spoke of the concealed abruption earlier. They'll have a tender abdomen, it'll be rigid, they'll be in pain, they'll have contractions that if they get on the monitor almost look like a sawtooth pattern. And they don't have a resting tone on their abdomen, which means their belly doesn't get soft after a contraction. And their baby will be reacting with late decelerations, most likely, if you have her on the monitor. Postpartum hemorrhage, going back to that, it occurs in 5 to 6% of all vaginal deliveries. Used to, it was defined as 500 cc blood loss after a vag. Now we've changed that across the board. It's now 1,000 ml loss for C-section or a vag. So a normal pregnant woman can tolerate a blood loss comparable to this amount. However, not all of our pregnant women are healthy, and we know that. So the issue with postpartum hemorrhage is that, as I spoke of, the tremendous amount of blood flowing through the uterus at that time, it's a matter of minutes before this mom has hit 1,000 mils, 2,000 mils, 3,000 mils of blood loss, and sometimes even I've seen 4,000 mils of blood loss, and that's a scary day. So the greatest risk for a postpartum hemorrhage is the first 2 hours after delivery. However, it can be common up to 7 days post-delivery, and it can even happen and has been recorded into 42 days post-delivery. So one thing that the American College of Gynecologists and Obstetricians are really wanting to make a shift from is that whenever a patient comes in, especially not pregnant, they're postpartum, maybe they're coming into an emergency department or they're coming into a family care clinic. Used to, we assessed how many babies have you had, when was your last baby, or when was your last menstrual period. And so we would rule out thinking of this mom as a postpartum patient because she said her last menstrual period was 3 months ago. Okay, well, she hadn't had one for 3 months and she had one last month. Well, that seems normal. So if she has some bleeding, you may treat her as a non-postpartum patient. However, we're seeing that there can be postpartum mortality and morbidity up to 1 year after birth. So it's really important to be assessing, has that, not just her last menstrual period, but has she had a baby live or stillborn, or has she had a miscarriage in the previous year? Obvious signs and symptoms: massive bleeding, multiple clots, the uterus, when you rub the fundus, if it's not firm, it feels like a bowl of jello, then that's an obvious sign. Also, distension and displacement of the uterus above the umbilicus and to the right, or it could be to the left as well. So really, we should see that uterus gradually going down. However, if it's felt above the umbilicus, then most likely you're full of blood and clots. Less obvious signs, just a little trickle that can be small to moderate, maternal restlessness, mom looking pale, tachycardia, tachypnea, pain, tenderness, abdominal distension. Sometimes these moms will just say, oh, my back hurts a little bit. And you're like, oh, you just had a baby. That's normal. Well, sometimes it's not. Sometimes she's hemorrhaging. A rigid abdomen. The pulse and the blood pressure are not always affected until it's severe. So if you're waiting for mom's heart rate to be 130 and her blood pressure to be 90/50, you may have waited a little bit too long. So watch for those more common signs. This just discussed hematomas. Another thing that I won't go over too in depth, but another thing you want to make sure is if your mom is having bleeding due to the nature of the trauma of having a baby, that you're wanting to check her vagina and her perineum area just to make sure that some of the bleeding that she may be coming in with, either while she's a postpartum or labor patient, or if she comes in after delivery and presents to the ED, or if she's in your ICU as a postpartum patient. Make sure that you don't forget to look at the vagina. So in the event of maternal hemorrhage, you want to notify the OB provider immediately. Get a second IV access. You should already have one, I would hope, but get a second one. Large bore needles, IV fluids, preferably LR. Get her crossed for blood replacement. Moms can receive O negative blood if you don't have time for that. Place, keep a Foley in, because if her bladder's full, it can cause further uterine bleeding. Of course, get a pulse ox, lower the head of the bed, keep her warm, and make sure that you're letting the family know. There's a lot of trauma that has come up from families and significant others being left out of the loop whenever this is going on. And especially now, since there's so much maternal death in the news, people are frightened after they have a baby or when they have a baby. If something goes wrong, they're afraid that she's going to die, and it's a valid concern in America these days. So of course, we want to give her oxygen. In L&D, we do 10 liters non-rebreather. And we do, during a hemorrhage, blood pressure, pulse, respirations every 5 minutes. I know on second floor, whenever we have a hemorrhage, we massive transfuse. So we try to use a blood warmer. And of course, are assessing respiratory status frequently to make sure that we do not fluid overload our patient and doing hourly INOs. And last but not least, if all of the measures that we try are uterotonics, Cytotec, Methergin, and Hemabate. Cytotec is a rectal placement of 1,000 micrograms. Methergin, if she's not hypertensive, Methergin can be given. It's an IM injection, and then Hemabate is our third resource and can be given IM as well, regardless of her hypertensive status, as well as infusing Pitocin IV. Sometimes our providers will give Pitocin 10 units intrauterine. We have a hemorrhage cart in L&D, and it has an ebb balloon on it. We are working to get an ebb balloon to be stocked in the ED. This is a balloon tamponade system. It's very self-explanatory. It comes with a QR code in the kit that you can scan. Everything's labeled that tells you what to do. And basically, you insert that balloon into her vagina, fill it with fluid, and that pressure holds up against those uterine arteries to constrict and kind of slow that bleeding, as well as has a tube to measure down so that we can quantify her blood loss. On the second floor, make sure we are doing quantified blood loss for all recoveries, and especially in our hemorrhages. Make sure you're getting that blood loss documented and keeping up with the true accurate losses. Once we get her into the OR, we could do a B-Lynch suture to ligate those arteries, and then in the uterus, and then last resort is we have to do a hysterectomy on these moms, which is very unfortunate because that means no more babies in the future for them. However, it could be a life-saving measure. So that is the end of the hemorrhage presentation. If you have any questions, please feel free to reach out to me by email or by phone. You'll have a great day.